Good afternoon and welcome to the first in a series of Burnett Solicitors webinars on rehabilitation. My name is Paul Brown and I'm Associate Solicitor within our serious injury team here at Burnett. If anyone that doesn't know about Burnett, we are one of the largest law firms across Northern England. We have offices here in Newcastle as well as 3 offices across Cumbria and Carlisle, Penrith and Cockermouth, supporting clients from coast to coast. However, because of our national reputation, we often support clients and families across the country. We are a full service law firm and provide holistic legal advice across all main legal areas, whilst our court protection team complements the support we provide to our clients and families following serious injuries. We also have conveyancing, family, employment and wills and probate teams of lawyers who provide invaluable legal support when it's needed the most. Our corporate and commercial teams are also available to support companies big and small with a full range of professional legal services. I'm very proud to work for Burnett and support patients and their families following serious injuries, including traumatic brain injuries, mainly spinal cord injuries, amputations and other serious injuries. I've worked solely for claimants for over 19 years, and our team of specialist lawyers have extensive experience of supporting people following head and brain injuries, which often lead to vestibular injuries also. By way of an introduction, I recall that I first came across vestibular injuries many years ago after supporting a lady who had a constellation of symptoms after what appeared to be initial information to be a relatively minor whiplash injury. What's often referenced as a rear end shunt after she stopped at some traffic lights. After going through her symptoms in detail, we referred her to an independent specialist consultant ENT surgeon, given a reference to tinnitus, and subsequently a diagnosis of BPPV was made. The lady involved was provided with case management support and importantly private rehabilitation treatment, including specialist physiotherapy, which improved her tolerance levels and to her symptoms. Although ultimately in that instance she wasn't able to return back to her previous high-powered executive job she had done prior to the road traffic collision, despite attempts to do so. The issue in that case was her being unable to tolerate looking at a computer screen for any length of time, being a particular barrier in that case. Since then, I've become increasingly aware of vestibular symptoms following head and brain injuries. At the seminar we did back in December, one of my previous clients came in to talk about her own personal experiences of vestibular problems. At the time of her injury, she had just left university and been working in a nursery and was actually knocked down by a car at a pedestrian crossing on her way to work. She sustained quite a very serious brain injury, as well as separate vestibular injury. And after we were instructed, which was still when she was in hospital, we obtained immediate interim payments through the legal claim to fund case management, treatment and support. This ensured that whilst she continued to receive NHS treatment during her time in hospital, including a period of time in the specialist neurorehabilitation unit here in Newcastle, i.e. Walker Park, there would be some private support available to supplement the support available in the community for her. We're very lucky in the North East to have community rehabilitation teams such as Northumberland Henry Service and the Cavis team in Sunderland and Gateshead, who provide treatment and support, including vestibular neurophysiotherapists. However, this is by no means universal across the North East and Cumbria, never mind across the rest of the UK. And one of the reasons for trying to organise this seminar today was to try and highlight the need for rehabilitation for this group of patients. In terms of the webinar today and our experts who kindly agreed to support the webinar today, our first speaker on the agenda is Claire Bates, a consultant vestibular audiologist with over 24 years experience within the NHS in the causes and treatment of inner ear, dizziness and vestibular problems. Claire recently won the British Academy of Audiology Award for Audiologist of the Year, and Claire now works in a private capacity for anyone here and can see patients right across the north to support them with inner ear dizziness and provide appropriate support and advice. We then have Lisa Robinson, who's a consultant allied health professional in major trauma rehabilitation based at Newcastle Hospital's NHS Trust at the RBI in Newcastle, and an honorary senior lecturer at Newcastle University. Lisa has kindly agreed to provide her presentation on the science and art of vestibular rehabilitation. And then our final speaker today is Gail Archer, who's a clinical lead occupational therapist at Neuropathways, based in the North East. I've worked with Gail for many years, and she has been an active part in many of the multidisciplinary teams of therapists I've supported through a number of serious injury, personal injury claims in the past. Gail is going to talk about the role of occupational therapists in supporting patients with vestibular injuries and functional rehabilitation. Please remember that today's seminar has been recorded to allow it to be shared widely and hopefully increase awareness of vestibular symptoms and what treatments are available for this group of patients. In order to keep the conversation going following the webinar, please use the hashtag #GettingBackOnTrack on Twitter. And I'll now pass you over to Claire Bates, our first speaker. Thank you.
Hi, I'm Claire Bates. I'm a vestibular audiologist. I'd like to take the opportunity to thank Paul for allowing me to speak today, and also to say that my talk is aimed to help you identify which patients or clients will benefit from vestibular rehabilitation therapy. So the topics I'm going to cover, initially it's basics of balance, and I'm going to explain this the same way as I would do to a patient, so I'm going to keep it extremely simple. Then we're going to talk about the symptoms which indicate an inner ear balance problem, and you will recognise that some of these, there's a crossover between vestibular rehabilitation and with concussion treatment as well. Then we're going to talk about vestibular conditions commonly associated with head and brain injury. I'm not expecting that you will be able to diagnose from my talk, more that you'll suspect the conditions and therefore steer the patient in the right direction. And then we're going to talk about goals of vestibular rehabilitation. The main thing is that it's not all about exercises, and then summary. Okay. So the human balance is made up of eyes, muscles and joints, and the ears, the inner part of the ear, which is the vestibular system. They're all finely tuned into a mechanism that's learned very early in life, and all parts are incredibly important. But as an audiologist, I'm most interested in the inner ears and the eyes. So the vestibular system, most people know where the outer ear is, and the pinna, and then the ear canal, the eardrum, then the middle ear, which is the air-filled space with the little bones in it, and then you look at the vestibular system. And the little picture that we have in front of us at the moment, the bit that looks a bit like Mickey Mouse ears, those curly canals there are the semicircular canals, and then they're attached at the bottom with a fat bit, which houses something called the utricle and saccule. So the semicircular canals are bone. They're filled with fluid and little hair cells. And if you can imagine the tide wafting over the top of seaweed, that's similar to the way that I picture the fluid moving over the top of the hair cells. So if you're moving your head left, right, up and down, forwards and backwards, then the fluid moves in those canals, shifting the hair cells, telling your brain where your head is at any one time. And ideally, you should have 2 ears sending the same information directly to the brain. The utricle and saccule do something very slightly different. They have little tiny crystals of otoconia, and the way that I picture them again for the patient is that there are hair cells that run up through a bed of jelly, and then on top of the jelly sit the otoconia, or the crystals. And basically they work with gravity. So if you stand up and sit down, the little crystals bounce and send information through the hair cells to the brain. If you accelerate or decelerate, moving forwards or backwards, again, the crystals slide, and basically, again, giving information accurately to the brain. Within the balance system, there are lots of reflexes, but the main reflexes that I am interested in are the vestibular ocular reflex, which maintains gaze stabilization. So if you look at a point, so if you're looking at the screen and move your head left or right, or look up or down, your eyes move in an equal but opposite direction. And that reflex is the second fastest reflex to the sneeze. If you move your head very quickly, still my slides will remain in focus, and that's all to do with that very powerful reflex. So that reflex, as I say, joins the eyes and the ears together. The vestibular spinal reflex, Lisa, the physiotherapist, will probably explain this in much better terminology than me, but basically it's all the reflex from the tip of your toes all the way up to the base of your neck. And that and the vestibular ocular reflex all work together in order to make sure that that we stay upright, balanced, and are able to move around with control. So, as I said, the human balance system, basically, the learning and the fine tuning happen from birth. So your eyes, ears, muscles, and joints all do, or they're all there, they're all present, or they should be, but it takes time for them to knit together and work as a team. So the slide that you're looking at the moment, the little baby at the top left-hand side, that's actually showing that babies can't maintain their own weight. They can't stand up initially, and we all know that. Basically, when they're born, they have to learn how to follow things moving around them with their eyes. Then in time, they start and realise that they don't like to be laid down, they like to be upright because they like things to be the way they should be, and they don't like things upside down. They will then start and maintain their own weight and move around. And if you watch them, they creep around the furniture to hold themselves up. And then they get to the stage where this little chap just below is standing like a little sumo wrestler. And basically that's to make sure that their balance is as good as they can be. Nice wide stance and keeping them nicely plonked on the floor without falling over. Then in time, they start and move around and gain the ability to turn and shift and hold on to things and multitask. But sometimes they get it wrong. So the top right-hand side shows as children get older, they still make mistakes and still injure themselves as per the plasters. Fine-tuning of the balance system takes up until they're about age 8. And the next picture, the gymnast is showing how well you can finely tune a balance system. But obviously we're all different. We're all born with slightly different genetics. And we're not all going to be fantastic gymnasts like that young lady. The thing is that the sooner that a human body can be put into a situation to start and learn movements, the quicker they will learn now. But they do take an awful lot of practice. So it's a slow process, it takes time and lots of repetition, lots of practice. So you can imagine when something goes wrong with it, it isn't going to be an overnight scenario in order to put it right again. So what happens when something's missing? So at the top left-hand side, you can see it's somebody playing blind man's buff. So their vision's being taken out of the system. And basically, you can see that instantly your hands go out in front of you as protection and reassurance that you're not going to bump into something. So that is something that's visible. It's visible to other people that person's struggling and what they're doing to control the situation. If something went wrong with part of their proprioception, so for example your knee, you compensate by using the other leg more. You may lean slightly, but again, it's a visible thing. It's something that people can see. Oh, that person's having difficulty, they're limping or they're leaning. When something goes wrong with the vestibular system, the next bit down with the big red cross, that isn't as easy for other people to see. And it's not as easy for other people to identify where the problem lies. So we spend an awful lot of time looking at people's eyes in order to work out what the ears are doing, and also what the vestibular system is doing. And then also we need to take into account that the eyes, ears, muscles and joints, all of that information goes into the brain, so the brain can then process and spit out what we need to do to maintain our balance, to compensate for any issues. Now, if there's been a brain injury, again, that information may be compromised or slowed down. So we need to take that into consideration when we're doing vestibular rehabilitation also. So head and brain injury and dizziness. What do we need to know about this? Well, we need to realise that it can be multiple vestibular conditions that the patient's presenting with. So if you discover one, don't stop there, because you might find in time that the patient is actually presenting with more than one. So the most common ones that we see are BPPV and vestibular migraine. They're the ones that we really ought to be looking out for with every patient who suffered a head trauma or head injury. Then you also need to take into account that recovery takes an awful long time. So some of these patients may have been bedridden for a long period of time, so therefore they're not moving around and they're not going into situations and not performing activities initially. And then over time, when they start to move around and they start to visit places, it becomes more apparent that they're struggling. So it's got to be something that's continually assessed over time. I've entered this slide in because I've struggled for years to find something that is easily, an easy explanation to patients of why, when they have an insult or problem with the vestibular system, why they struggle with things like mood, with confidence, with ability to multitask, with their memory and concentration. And this lady, Dr. Alicia Raffaella, has released a written information within the Spin magazine of the Meniere's Society, explaining how she sees the vestibular system as being one of the pivotal mechanisms of human life. And I have to agree, it doesn't just play a role in balance, but it also plays a role in the way you perceive things, your cognition and your emotion. So symptoms can, to us, seem very obscure and quite hard to pinpoint, and it's because they're all rolled up in one bundle, and it is quite amazing to think that is the case. So BPPV, what does it stand for? So benign is non-life-threatening, paroxysmal is quick, positional is that the head needs to be in a certain position for the patient to feel it, vertigo is the sensation of movement. So it is the most common cause of dizziness throughout the age groups, and as a vestibular audiologist, we spend an awful lot of time treating this. It's classed as being autocranial detachment, so it's when those little tiny crystals that we talked about being in the utricle and saccule escape and end up floating about in those semicircular canals that we were talking about earlier on. Now, initially with traumatic brain injury, it can be multi-canal. If you imagine that your brain has stopped very quickly and thrown those crystals out, if you imagine them being like putting sugar in tea, it takes a little while for them to drop to the bottom. And initially, they will be floating about in all canals, but over time, in theory, they should drop to the lowest canal, which is the posterior, and that's why posterior canal BPPV is the most common cause of that we see. I've also put that it can be silent, and that's because the more traumatic the brain injury is, the less likely the patient is to explain the symptoms as being the same way as somebody without the brain injury. So they might describe feeling unsteady, or they might appear unsteady, but they often don't feel the dizziness. They're not aware that their eyes are moving in a way that would make them feel dizzy. Rotatory vertigo is the spinning, and you would expect the spinning to be fairly short-lived, seconds to minutes, and that's largely because it takes seconds to minutes for those autocornea to come to a stop. So if you look up, the little crystals move, then they stop, and that's when the eye movements stop and the dizziness stops. As soon as you move your head again in a way that aggravates those crystals, the dizziness is there again. And classically, patients will describe reaching up, bending forward, lying down and turning over in bed as being the evoking movements. It can make people feel quite nauseous, and the way to treat this condition is something called a particle repositioning manoeuvre. And again, we spend a lot of time repositioning these otoconia that have got out of where they should be. The classic types of treatment you would be looking at are Epley manoeuvre or Seamont liberatory manoeuvre, and if you even referring to a physiotherapist with knowledge in this field, an audiologist or an ENT doctor, or even GPs as well. A lot of GPs are trained in performing these manoeuvres. The next slide's examples of types of visual vertigo. So how many of your patients have said that they feel unsteady or uncomfortable, dizzy even, when they walk into a supermarket, when they watch a river flow past them, or try and cross over a footbridge across a busy motorway? That's all quite classic. But patients can also perceive the ground to be moving. If you look at the top left-hand side picture, it does look as if it's waves, and that's actually flat. And the bottom right-hand side picture, it's a flat floor, but to them, they might perceive that as blocks and feel that they need to almost step on the blocks. Again, they might feel really unsteady if they, say, got up in the night to go to the toilet and didn't try and switch the light on. Or if they walked out and it suddenly started to snow, and the movement of the snow within their vision makes them feel funny. And it's all to do with this mismatch of information, which I'm going to talk about next. So, mismatch of information between the eyes, ears, and muscles and joints. So imagine you're going to stand on an escalator, and you stand still on that escalator. So your muscles and joints are telling you you are standing still, but your eyes are telling you you're moving. Now, your ears, in theory, should be the deciding factor, but the ears aren't working as well as they should, so they confuse things, and it's that makes the patient feel uncomfortable, unsteady, and wanting to get off. It's the same if you sit in something. If you sit in something that's moving, your body, your muscles and joints perceive that you are sitting still. Your eyes are telling you you're moving, so therefore your ears again are the deciding factor, and you can see the pattern here, or the trait. Confidence is a massive area again with vestibular rehabilitation. The more confident the patient is in what you're asking them to do, the more successful your treatment will be. But confidence is something that takes a huge knock when somebody has had a head or a brain injury. So if you imagine all those gentlemen are sitting only 5 foot off the ground, then you can imagine that they would be sitting there quite happy and not being particularly petrified. But if that's miles above the world, then you can imagine them being fearful. But the idea is that these guys have tricked their brains into thinking that that bar is only 5 foot off the ground, and their vision, they don't take an awful lot of information from their vision, that they're just going through practice, what they do every day. The main thing is that you need to persuade the patients that the information coming through is going to be useful, and therefore they can rely on it. The more fearful they are, the more likely they are to find things that they considered easy beforehand not something that they can cope with at all. But everybody's different. Everybody has different levels of confidence. The next slide's an example of your normal thought pathway. So you have hundreds of thoughts flying around in your head at the moment. Maybe how long will this talk go on for? What's the slide going to be next? Have you remembered to bring your face mask with you? What will you be cooking for tea? These are all just normal everyday thoughts. But if you have a problem with your balance that was initially something that you did without any real thought put into it, subconscious, then this is what you find. Because you're having to think about your balance all the time, and accommodate that, then you find that you can't remember simple things. You can't remember what you've gone upstairs for. You've gone into a supermarket for 3 items and you can't remember what they are. You're constantly tired because you're using an awful lot of thought put into something that, again, you previously didn't have to, and you find concentration really quite difficult as well. So maybe it's no surprise that when patients present to us with this all going on, that they're frightened because they don't know what the future will hold. They may be really tired because they haven't just got this going on, but they've also got lots of other things going on around them, and rehabilitation is hard work as well. They could be worried, upset, embarrassed, feeling that maybe other people don't understand that they've got an inner ear balance problem, but that maybe thinking that they've had something to drink. A lot of clients do think that way, and they might be angry. Why is it taking so long to get to this stage, and wanting answers? So what are the goals of vestibular rehabilitation therapy? Well, the first thing, and I would say probably a huge amount of the first appointment, is education. You need to educate the patient in what the vestibular system does and how much reliance they put on it. Then we need to talk about realistic expectations and acceptance. I don't rose tint expected outcome. I've got to be genuine and straightforward with the patients from day one. Otherwise, they won't appreciate where I'm coming from, and they won't accept my advice. They'll have no faith in what I'm telling them. So then we need to understand what their limitations are, because we need to make sure that they are careful and that they're safe through treatment. We need to talk about management strategies, because ultimately that could get them up and moving around fairly quickly. And then we need to personalise an exercise programme for them. The personal exercises need to address their concerns and their areas of weakness. They don't need exercises that work with absolutely everything. And we need to find out what activities they find difficult in order to pop those into the programme as well. So management strategies. Well, the first one that we look at is using their sense of touch. Remember the idea of putting the hands out and using the proprioception more. That comes pretty much right from day one, and patients work that one out. They do what's called furniture walk, or they hold on to walls or hold on to somebody else for support. It may be that in order for them to keep their independence, that you want to talk to them about using poles. It might be that you need to talk to them about what they're wearing on their feet. Particularly ladies, when they're coming in to see us in the hospital, they come in smart, so they might even have attempted to wear a kitten heel. But the idea is that the more information or contact that they get from the floor, the more helpful they will find their balance. Imagine how hard it is walking around on your tippy toes all the time. And in theory, once you put a heel on, that's what you're doing. So you need to use good shoes, solid shoes, and ones that don't bounce too much. If you consider their own homes, you might need to talk to them about using a dual banister instead of a single one. And you might need to explain to them why they feel more comfortable or more confident on a stable base, for example, concrete as opposed to grass, pebbles, sand. Anything that moves under their feet is going to be a much harder medium for them to actually walk on. And you do need to explain why that is. Fixed focal points. So most people with a balance problem tend to look at the floor, but the floor, other than telling them that they're not going to trip up over something or stand in something they shouldn't, isn't going to keep them straight. One of the things that your ears do, other than recording movement and helping you understand where you are in the world, is help you walk straight. And if you've got one ear that's not working very well, sending incorrect signals to the brain, then you will veer. And that's one of the things that we need to stop from happening, keeping people on their feet, preventing them from falling over, and keeping them straight is with the use of fixed focal points. So if they were walking through Eldon Square, it was exceptionally busy, then they need to be looking up a height. So they're looking at maybe a clock, a window, something in a window, something that they can use as their target. In the house, it can be door frames, it can be door handles, it can be peepholes in the door, it can be anything that they can get a gist of, okay, that's where I'm going, that's where I want to be, and that keeps them in a straight line. Fixed focal points also work on things that are moving. So if the client describes feeling unsteady when a cheetah runs across a plane and the video camera is following them, that kind of movement, then you can put a fixed focal point in the top left or right hand side corner of the television. If they struggle with scrolling on a mobile phone, then just putting a Tipp-Ex mark or a small sticker on the phone will help them gauge that it's what they're looking at that's moving and it's not them that's moving. And the same applies with computers, iPads, anything like that. It's kind of the old look for land scenario. So when you're on a boat and things are moving, then you would look for land, and that helps override the information within you. And it's that kind of idea. The next bit is that there are certain things that will prevent patients improving, and being stressed, tired, or unwell are three of the biggest ones, and they can actually cause what's called relapse as well. So the patient goes backwards instead of forwards in recovery. So the guy's holding his neck there. When you have a problem with balance, what you tend to do is stiffen your upper body, because you don't really want to move your head, because when you move your head, you feel the symptoms. And that's, again, it's to do with this eye-ear scenario. So if you loosen the neck off, that can make things feel a lot better. It can make the exercises that you're giving them more comfortable, and prevent them carrying their stress in their neck and their shoulders. So that's one thing. Good sleep pattern almost reboots the balance system. So they will feel better if they are getting a good night's sleep. So that's certainly something that we can possibly help with. And there's also relaxation, forms of relaxation that can help, and that can be Tai Chi, it can be breathing exercises, it can be just having a pleasant bath, anything like that that just allows everything to settle down. You will have heard the scenario, if you don't use it, you lose it. So basically, we want them to try not to avoid certain movements or try not to avoid certain situations. Otherwise, they will never learn how to cope in them. So there's also the point of limited exposure. So if a certain position or certain movement is uncomfortable, then just doing little bits of it regularly will be better than avoiding it completely. And that's something that you need to talk them through. Walking outside every day is really beneficial to their confidence, and it also gets them some natural light. Natural light for your balance is much, much better than artificial light. So the more time you spend in artificial light, the less improvement you will see. Speed of body movement is something that comes with lots of practice. Initially, you might only get your client or patient to move the head quite slowly, and that's because with slow head motion, you get a lot more information through the vision to where they are. Quick head movement, as soon as they move the head quickly, their vision becomes a blur, therefore they feel less comfortable. So it is something that you need to build up slowly. And they find that they can't negotiate things like rugs, pet dishes, steps. But again, with practice, they should be able to work around these. And remember, this can take an awful long time to do with some head and brain injuries. So why are these activities difficult? So we've talked about the eyes being used a lot when the vestibular system's compromised. So the more information that the eyes are having to process and the brain is having to process, the less time it has to focus on balance. Therefore, you do feel uncomfortable. So Christmas is actually a really good example of that because it's got lots of flashy lights. You spend a lot of time maybe travelling about. You're having to think about 101 things to do with children and presents and food and everything else that goes around Christmas. So Christmas can be very difficult for people in recovery. Family groups, again, there's an awful lot of processing of information in there, and patients with head injury, brain injury or vestibular weakness, they often find that they need to slow things down and do things at their own pace and not multitask. So maybe having a conversation with one person at a time is easier than doing it in a group format. Reading is using that vestibular reflex in a slightly different way. So if you imagine that when you're reading, your eyes are working a bit like a typewriter, they're still working along to the right and then flicking back to the left, along to the right and then flicking back to the left. It's using that same mechanism. The words can become jumbled to these patients. They can find that they can't concentrate for long periods of time, or they forget the information. So to slow it down by using a plain white sheet of paper over the top of it, like being back at school, this can help and slow things down and make it more manageable for them, even if they're able to do it just for a very short period of time. And again, the bottom one, if your client or patient is thinking about going back to work, it's often a good idea to have a conversation with them about what they will be able to cope with and what they potentially won't, and spacing things out, or looking at ways that they can practice activities or tasks at home before going into the work environment. So positivity and realistic expectations. It's rare that improvement is a lovely straight upward line. Often patients or clients will improve a bit and then they might go back very slightly, and then they'll improve a little bit more, and again there might be a bit of a bump in the road and they go back a bit, and it's all part of learning. They will then occasionally try and do a little bit too much, which will knock them back a little bit, and it's all understanding why that is. So you often do need to explain why they have good and bad days, or when recovery is really taking hold, why they have a few good days or a couple of good weeks and then their symptoms appear to recur. A positive mental attitude is always really important with any recovery. That is very definitely something that you need to keep going with them. Building a good rapport with the client often helps, and supporting them, explaining why friends and family around them understanding their condition and helping them, that's a real must as well. So often I do have more than one person in the room, or when the client comes, they might bring somebody else with them. This is all pre-COVID, mind. Realistic goals. So this is really just a little bit of fun. So the basic is, if you give them unrealistic goals, you make it too challenging for them, all they do is get disappointed. It has to be realistic. It does have to be slightly challenging, but it definitely needs to be manageable. So it's a long day playing golf if you don't know where the hole is. That's something that just came to mind when I was thinking about realistic goals. Vestibular exercises. So these are all exercises that I might use. I may use a little bit of one and a little bit of another and mix another one in as well, but I don't give them loads to do. I think it's probably enough to say if they are doing 10 to 15 minutes of exercise morning and evening, that is sufficient. A lot of these clients or patients have more than our exercises to do. They might have physiotherapy, they might have activities that their case managers ask them to look into. So we don't want to overload them. And this is an example of the different types of equipment that we might use within the clinic. So to summarise, When dizziness presents, always ruling out BPPV, I would say, is very, very sensible because of how common it is. Always remember that it takes a long time to recover from a condition. So their presentation will change. They might show different symptoms, months down the line or even years down the line. So we do need to keep observing and watching out for that. Early intervention is definitely key. They see the biggest improvement early on, and if you can get involved in that, then that is very, very, very good for the client or patient. You've got to watch for the multiple diagnosis. As I said earlier, BPPV and migraine are the two most common, but you just need to keep an eye that you're not missing anything. Vestibular function testing, there's a huge range of vestibular function tests that can be done, and it can be really helpful to narrow down the area that the patient's particularly going to struggle with. But if the patient's presenting classically with, say, visual vertigo or BPPV, for example, then there's no harm in starting vestibular rehabilitation therapy. The vestibular function test might not be something that the client or patient can cope with right now. It might have to be something that they do further down the line when they're more capable and able. But they are definitely two areas that you need to put some consideration into. And lastly, it's worth mentioning that if there's been trauma to the vestibular system, has it upset the hearing? And are they struggling with tinnitus? Because those are two areas that, as a vestibular audiologist, we look at as well. So it's key. Obviously, if they're not hearing very well, that can upset the cognition. And if they're constantly being irritated by a noise, a tinnitus, then that might be an area that needs consideration with rehabilitation as well. So thank you very much for listening, and please stay safe and enjoy the rest of the talks.
Five?
1, 2, 3, 4, 5.
Perfect, thank you.
Slides.
Yeah.
So thank you very much for the invitation to speak at today's webinar. My name's Lisa Robinson. My current role is Consultant Allied Health Professional, and I work in a major trauma rehabilitation service at the RVI in Newcastle upon Tyne. Just to explain a little bit about me and my background, I am a physio by background, and prior to being in my current role, I worked as a physio in a falls and syncope service for 13 years, so saw lots of patients who presented with falls, balance problems, dizziness and blackouts, and that's where I learned more about vestibular rehab. With our major trauma population, obviously they do tend to present with dizziness problems at different times throughout their rehab. But really, just to carry on with my presentation, just to make the point that vertigo and dizziness are not diseases as such, but they're symptoms. So if a patient presents with dizziness, there could be a variety of different underlying causes, and they may be neurological, so the patient could have a head injury, they could have a condition like multiple sclerosis, MS. It could be a cardiovascular cause, so the types of things that we used to see in our falls unit, so things like postural hypertension, OH, where patients perhaps when they stand up very quickly get a drop in their blood pressure, and that can make them feel quite dizzy and off balance. It could be vestibular, so it could be a condition like BPPV, which Claire has obviously touched on in her presentation. And there could be a psychological component as well, so it may be that a patient is hyperventilating, for example, and that's making them feel dizzy. And with some of our patients, they may actually have more than one type of dizziness. And particularly if patients have had dizziness for quite a while and it becomes a chronic problem, then there often is a psychological component, and it's just being aware of that. And I know Claire spoke a lot about the importance of confidence. So what is vestibular rehab? Quite a wordy quote here, but vestibular rehab is a specific form of physical therapy which is designed to habituate symptoms and promote adaptation to and substitution for various aspects of deficits related to a wide variety of balance disorders. And the reason that I've included this slide really is just to see how multifaceted vestibular rehab is as a therapy. And the three terms that I've highlighted there, habituation, adaptation and substitution, are really important to understand as a therapist prescribing vestibular rehab, and also in terms of educating patients and their family members, because if you understand what it is that you're trying to achieve and why, obviously, hopefully you'll be more effective in your approach. So in terms of the goals of vestibular rehab, they are also multifaceted, as you would expect. So we're often wanting to decrease symptoms of nausea and dizziness. Obviously they can be incredibly distressing and incredibly disabling for patients. To improve their balance and their gait, to reduce or prevent falls, to improve the ability to see clearly during head movements, to maintain or improve independence in their activities of daily living, to maintain or improve physical activity levels, and to promote education to the patient and their family, because often these symptoms have been happening for a long time, or they may be particularly troubling. And a lot of the time, patients and also different healthcare professionals may actually think that dizziness is something that just has to be put up with, and actually there's often a cause for that, and more importantly, that cause is often treatable. And to reduce fear and social isolation, because again, when patients get into a little bit of a vicious cycle where they have dizziness, they stop doing things, and then because they stop doing things and they're not as active, they get weaker and then they become more off balance. So it's really important about being clear of what the goals are for vestibular rehab, and obviously they should be discussed with the patients and their family members to make sure that we're working towards common goals. So I also wanted to say a little bit about prognosis, because often people are unclear about what we should be aiming for and what we're able to achieve with vestibular rehab. And the point that I wanted to make, that often prognosis isn't related to age. So sometimes there's a perception that as people get older, it becomes more challenging to deal with balance or vestibular problems. And sometimes that's the case because as people get older, they have more conditions, or they may have problems with their vision, with their joints and their muscles as a result of wear and tear. But age on its own isn't a reason to think that somebody won't improve from vestibular rehab. Gender, chronicity as well. So sometimes the longer people have had dizziness for, the more complex it can become, because people will adopt avoidance behaviours. They may have a psychological component to that. But just because somebody's had dizziness for a long time, it doesn't mean that they won't get better or they won't be able to improve with vestibular rehab. There are some important things to consider though. If they have central involvement, so if they have a brain injury or they have a condition like multiple sclerosis, as Claire was talking about, sometimes it can be more difficult for them to adapt to some of the therapies, and it might take longer, and it might be that when you're counselling the patient or liaising with other healthcare professionals that you want to be clear about that. If they have bilateral vestibular involvement, so affecting both of their ears, obviously that can take a little bit longer. There are certain medications which cause vestibular suppression and actually can make it more challenging to bring about long-term changes, and that might be something you want to discuss with patients and discuss with medical staff. If they have other physical comorbidities, that can obviously make things a little bit more complex. And as I've touched on before, if they have psychiatric or psychological factors, obviously that's not a reason not to start on a vestibular rehab program, but it might be that you need that really important multifaceted or multidisciplinary approach. So in terms of the types of approaches that you would use for vestibular rehab, I know Claire talked quite a lot around BPPV, and I'm not really going to touch on that so much in my talk today. What I'm going to concentrate on are these three terms: adaptation, substitution, and habituation. But as I say, vestibular rehab is really multifaceted. So thinking about incorporating some postural control exercises for balance, thinking about functional mobility, thinking about deconditioning as well, and particularly if patients have become avoidant of certain activities, then thinking about the effect that's going to have on the musculoskeletal system and generalised weakness. Education, again, really, really important to explain what you're doing and why. And often if patients can understand some of the very basic principles of vestibular rehab, it's much easier to get buy-in, and also for them to self-manage and progress their own exercise programs. And again, the importance of goal setting. So going back to those three terms, in terms of adaptation, this is the ability of the central nervous system to make long-term plastic changes in the neuronal response to input. So this is about bringing about central compensation, and exercises are needed to cause a stimulus that produces an error signal to make the central nervous system modify the gain of the vestibular system. And it's that error signal, that slip of an image across the retina, that brings about those central changes. And the purpose of adaptation is to be able to see clearly during head movements. So these are the exercises that you would commonly give to people where they fix their eyes on a fixed point and they move their head accordingly. And what you're wanting to do is actually provoke their dizzy symptoms. So in terms of gaze adaptation exercises, there's lots of possible progressions, and sometimes it's worth thinking about these and thinking about what it is that you want to achieve, but also explaining the principles of this to a patient or their family so that sometimes they're able to progress themselves if there's time between their therapy sessions. So it might be that we start in sitting and we progress to standing, and it might be that initially you want to do the exercises in supported standing. So perhaps somebody is going to stand at their kitchen bench so that they've got the bench to support them, because we are making people feel dizzy with these exercises, so it's really important that they feel stable. And then as the exercises become more challenging, because as the vestibular system and the central adaptation occurs, we need to keep challenging people, and things that were hopefully difficult at the beginning of therapy will now become much easier. What we might want to do is put them into step standing, so giving them a reduced base of support. As I've mentioned before, they might want to have something to put their hand on for support. As they become more advanced, you might want to take that support system away. You might actually want to get people to do things on a compliant surface, so standing on foam or other unstable surfaces to challenge the balance system. As I mentioned before with the gaze adaptation exercises, they're very much fixing their eyes often on a target and moving the head. And so what you can do to make it more challenging is you can move the size or the distance of the target. So starting with quite a big target to focus on and making that smaller, or also moving the target closer or further away. And what we know about these reflexes is that when we are recalibrating them, they are very context specific. So if you always do an exercise at arm's length away, you'll be able to focus on objects which are about that arm's length away, but perhaps something closer or further into the distance will still be quite challenging. The plane of movement is also something that you can adapt, so you can do horizontal head movements, but if vertical head movements also provoke dizziness, that might be something that you want to think about incorporating. The speed of the head movement is also something that you can think about, so initially starting relatively slowly, but also making sure that the speed of the head movement provokes the dizzy symptoms. And as you want to make the exercises more challenging, thinking about speeding up those head movements, and also the frequency. So moving on to habituation. Habituation is slightly different, and they are distinct treatments, and as I say, with a multifaceted exercise program, you might want to incorporate different elements of these. But habituation is that repeated exposure to a provocative stimulus will result in a reduced pathological response. So some people may be familiar with the Cawthorne-Cooksey exercises, and the principle behind these is habituation. And a little bit as Claire said, we are very much, if certain movements make us feel dizzy or off balance or unstable, we'll avoid doing those movements. And actually, through a graded exercise program, encouraging patients to start moving in those ways again, we can often have a really beneficial effect on their dizzy symptoms. So I mentioned before that with our major trauma patients, and some of those patients won't have a head injury necessarily, they might come in with multiple fractures, but because of the mechanism of their injury, because they've been involved in a road traffic collision or something similar to that, what we sometimes find, just because of the mechanism of the injury and the fact that everything's been shaken up, is that when they come to us to start their inpatient rehab and they start becoming more mobile and moving around a little bit more, they start experiencing dizzy symptoms. And sometimes they may just improve just because they're becoming more active and they're doing more movements with us. But sometimes that actually might be quite a big barrier to their rehabilitation, and actually their dizziness might become the main problem, and that's when possibly we need to start thinking a little bit more and perhaps doing some more sort of structured assessment around that. So substitution, Claire again touched on this, but this is the use of alternative strategies to replace lost or compromised function. So for example, if somebody has a peripheral neuropathy and they don't feel their feet so well, it might be giving them a walking aid or relying on visual cues. The disadvantage of substitution, as Claire said, is that individuals will be at a disadvantage if the substituted cues are inaccurate or unavailable. So if they're walking on uneven surfaces, if they're in a very unpredictable environment, if they're very reliant on their vision for balance, they're going to find it very difficult if they're in a darkened environment. Claire mentioned escalators because of the mismatch between the signals from vision and proprioceptive cues, or again if they're in very busy, crowded environments. The other thing that I just wanted to touch on today was visual dominance, and again this is over-reliance on visual cues for stability. So sometimes this can happen in patients who have vestibular disorders. Sometimes we find it quite a lot in our older patients because they have wear and tear on the joints. They're generally a little bit more cautious and a little bit unsure. Often people with visual dominance experience quite severe symptoms, and they're often triggered by rich visual surroundings such as busy, crowded environments, escalators, as Claire touched on, and moving walkways, TVs and computers, or anywhere where there's quite visually dominant patterns. And again, it may lead to avoidance behaviours. Treatment for visual dominance is really difficult, and what we ask patients to do a lot of the time, or what we try to re-educate, is an increased reliance on proprioceptive cues. Giving them exercises to do with their eyes closed, giving them exercises to do where there's a busy visual background. Sometimes we can use videos, sometimes simulator-based treatments, virtual reality, and actually graded exposure to some of those provocative environments. So just to conclude, I appreciate that it's been a bit of a whistle-stop tour through vestibular rehab, but the take-home message is certainly from my point of view is that what's really important as a therapist is to think about customised exercise programmes based on your own assessment findings, and they are the most effective. So giving out exercise sheets is fine, or directing people to web-based resources is fine, but it's not the same as assessing a patient and being able to give them something which is much more customised. It's really important to follow a problem-orientated approach, so taking the time to find out what the patient is having difficulties with, what their family feel the problems are, and trying to incorporate those into the exercise program, and making sure that the exercise program or the treatment program aligns with those functional goals. Regular reassessment and progression is really important, so as people hopefully get better and they improve, things that hopefully made them feel dizzy at the beginning perhaps aren't going to make them feel dizzy later on. And so it's really important that you progress the exercises as time goes on. And then the final take-home message from me is that individuals need to work at the limits of their ability, so they must be challenged. And again, that's a really important educational component, is that often patients will avoid doing things that make them dizzy, and what you're doing is encouraging them to feel dizzy with some of the exercises, but doing that in a very controlled and structured way. So thank you for listening to my presentation. I've included some of my contact details there. As I say, there's my email address, my work telephone and my Twitter handle. Thanks.
You got 1, 2, 3.
1, 2, 3.
Perfect. On to you, Sam.
Hi, thank you for asking me to talk today about the functional rehab for vestibular disorders. For those of you that don't know me, I'm Gail Archer. I'm clinical lead occupational therapist at Neural Pathways. We are a private sector therapy provider based in the North East, and we also have offices in Scotland and the Midlands. And really today it's an opportunity to talk about the kind of occupational side of things and the functional rehabilitation for clients who experience these disorders, because as Claire and Lisa have both mentioned, quite often clients avoid situations that make them dizzy, and as we'll talk about in a minute, the world around us is a massive challenge for some of these clients. So in terms of the stuff that impacts on quality of life and participation in everyday tasks, the vestibular symptoms can affect things like bending and reaching, so bending into cupboards to retrieve items, reaching up to pick your coat off a coat rack, and those can make the clients feel quite pushy, I think is the description that we usually get, is where they get that rush and they feel really unsteady. The new iPhone technology is the latest one, which I've just experienced with a client recently who went to purchase his new iPhone, and they do facial recognition where you have to look at your phone and you have to turn your head from side to side, which is one of the things that just sets off symptoms for a lot of clients. Shopping, as we'll talk about later on, going into busy shopping environments where there are lots of different colours, sizes of boxes, items of various descriptions, as well as other people, can cause people a lot of distress in the social situations. Travelling on public transport where you're not in control of what movements are happening around you can be really difficult, especially where there are problems with proprioception, vision and the kind of injury to the vestibular system, which then leads to that avoidance. Clients can become quite socially isolated or only willing to travel within their local communities. Participation in leisure activities, which we all take for granted. There are things that we do every day for enjoyment, and quite a lot of times people with vestibular problems will withdraw from those things. And then employment, which I'll talk about later, about a small case study that I'll talk about a lady who employment was really going back to her previous employment after her brain injury with her vestibular problems was one of the most distinct problems for her. So as we've mentioned, the clients often avoid situations that exacerbate their symptoms. It leads to isolation, loss of vocation and purpose in their day, frustration, avoidance of functional situations, and this becomes an all-encompassing thing for their daily life. So the need to approach this on an MDT basis is really important. Obviously you have the kind of medical audiology and physical rehab side, but it's important that the psychological side isn't missed, as well as the ability to function on a daily basis. So as an occupational therapist, our role is to help people of all ages to overcome any permanent loss or lack of physical, sensory, mental or communication function. The aim is to help people to improve their ability to function as independently as possible and to participate in whatever meaningful activities are important to them. Occupational therapists do this by identifying and eliminating environmental barriers to independence and participation in normal daily life and exploring new ways of doing old tasks. So basically it's rehab in a nutshell, the same as Lisa talked about earlier. So in practice, from an occupational therapy perspective, we do a lot of graded approach to community exposure. This community environment is really challenging, and as I'll talk about in a minute, it's one of the biggest barriers to people being able to access their daily life. Functional application of strategies for managing symptoms, where Lisa and Claire have talked about the kind of substitution, restoration, etc. It's then the clients being able to carry these things over into daily life, into everyday tasks. Looking at increasing the complexity of tasks and the environment in which they're going to be done. So it has to be that real life exposure to symptoms. So taking clients into places that expose them to their symptoms and helping them to develop strategies and compensations in those environments. Liaison with physiotherapy in terms of the exercise programmes, and as we talked, Lisa talked about, that kind of proprioception and ability to stabilise their gaze and their reducing the dizziness and head movement. One of the biggest things for me at the moment is around the access to clinical psychology or neuropsychology. So helping clients to deal with the frustrations that arise from these symptoms, because they can be really distressing to cope with. Employer education, helping employers to understand the nature of vestibular problems and how they present, and then also the environmental changes that can help people to maximise their independence and their functional performance. In terms of the graded exposure, I'll touch on a client that we did quite a specific programme around access to shops. In terms of the environments that we go into, there are lots of different places. We have high-end shops where there's very limited stock on display. They're quite quiet. They're quite understimulating, so they're slightly easier for clients to cope with. And then we have other stores where, as we can see from the slides, there are masses of different colours, sizes of boxes. They're all on different shelves. They're high. They floor to ceiling. And it can be really distressing for clients, because that overstimulation can just result in them feeling quite disorientated and unable to cope with the situation. And then we have places like B&Q, where I have a particular client that B&Q was her nemesis. She physically couldn't stand in B&Q because of the height of objects above her. And she said that she was acutely aware of all of the shelves and everything on them, that she then would become quite unsteady and unbalanced. So she just didn't like to expose herself to these situations. So one of the things that we did with her was that we did basically work up these environments. So we started out with a visit to a small local shop that we knew was fairly under-decorated. It didn't have lots of flowery wallpapers and lots of things on the walls and things where there wasn't a lot of stock on display, and we just would spend time walking around these environments. Then we would go to a corner shop, or we would go to an Asda's, or we would go to a Morrison's, and gradually build up to things like B&M stores, which can be really disorientating. And then our final trip was to B&Q, where she managed to cope for 15 minutes and buy 2 pots of paint that she'd been putting off for quite a significant amount of time. So it just showed that over a period of time, that exposure to the environments that caused her symptoms, and the ability to spend time and having quite clear goals of what those times were, helped this lady to move forward. She managed to do a lot of this independently. So we would have a goal of that by such and such a date you will be able to spend 4 40-minute sessions a week within the shops that cause you the distress, and that once you're able to cope with that, then she already knew what the next goal was, so that she was able to anticipate that in advance. But the other challenge for this lady was actually getting to the shops in the first place. She was a non-driver, always had been. She used to use public transport to and from work, and she found that she couldn't cope with travelling in anything other than a taxi. But she wanted to get back to her independence of being able to leave her house, go and do what she needed to do and to come back without having to sit and wait for taxis to arrive, because as we know, they're not always the most dependable on when they'll arrive. The first day that we went out to do the assessment, we literally went to the railway station and stood on the platform, backs against the wall, and watched a train come into the station and leave the station. And for that lady, that was enough. That her symptoms were exacerbated massively. She felt really dizzy, she felt disorientated, she felt really sick, but she had done it. So what we did over the course of a couple of weeks is we would go and just stand in the railway station. We worked up to standing away from our backs being against the wall, so she didn't have that kind of fixed point of reference physically. We started to look at how she was coping with things coming out and going out of the station without feeling too dizzy. Over time, we then agreed that we would travel into town on the train. So we had to physically get on the train and travel together. And again, that involved a period of a couple of weeks with travelling with me and then her doing it on her own and looking at strategies that she could employ during that journey. The first journey was great going in. She was facing forward. She felt really orientated. She was fine. More people got on the train. It was busier. She then struggled. For this lady, what she found actually on a train was to travel backwards was easier for her because she couldn't see information coming towards her, so she didn't have the pressure of having to process that information quite quickly. She was better if she could just see it going away because then she could process that in her own speed. We would then get off the train, literally sit in the station for a drink, get back on the next train home. We did this over a couple of weeks. And then we built in walking up to the local coffee shop and then back to the station. So again, we added in more stimulus, and gradually her goals were for her to independently travel on the train into town, get a coffee, go and get one item from a shop, and then get the train back. And she had this all integrated program that she worked through herself to the point that she now can travel into town, go to 2 or 3 shops, and then return back home without her symptoms being excessively difficult for her to cope with. So as we see, what we then built up, so we've gone through standing in the station, travelling on the train. She then travelled to B&Q, then she walked up to the town and was able to walk around the shopping centre, and these are things that this lady's still working on to this day. But she knows that the important thing for her is that she knows that she can do it, but she also knows that if she stops doing it for a period of time, these symptoms will then be exacerbated again. It's something that she needs to continue to expose herself to. It's not something that you do as a one-off and then you don't have to do again. It's something that she has to repeat regularly. When this graded exposure is continuing, the important things for clients to understand is that, and to expect, is that they will be tired, they will feel sick, they will have a headache, they will struggle with conversation sometimes whilst they're out and about, whilst their symptoms are being exacerbated, but actually to know that that's normal and that that's what we're trying to achieve, so that they don't then become people that repeatedly cancel therapy sessions or to avoid doing these things. So it's important that they understand that and that they again have that support from therapists but also from psychology to look at making sure that they are able to cope and have almost anxiety management strategies in place to help them to deal with these things. In a work environment, over the years things have progressed to quite often hot desking and things being the going way of working. And this is really distressing for clients with vestibular problems, partly because of the kind of visual stimulus that goes on, but also because of having to walk around in environments where there's lots of activity, noise, you've got bright lights, artificial lighting, etc. So as an occupational therapist, we do a lot of employer education to help them to understand that sometimes adjusting the work environment can allow a valuable employee to return to their work, which is great for the employer, but it's also equally great for the client that they've been able to achieve their goals of returning back to what is an important part of their daily life. I'm just going to go back to that slide, sorry. This is probably a good point to mention the case study. The lady that it's regarding has given us permission to discuss her case, and she ordinarily would come to this to present herself, but unfortunately due to work commitments, which is a great thing that we'll touch on in a moment, she was unable to come today. So this lady was knocked over on a pedestrian crossing outside her work. She had quite a significant brain injury, spent a period of time in acute and post-acute rehab before returning home to live with her parents. One of the most significant problems that she had was her vestibular problems. She would regularly have periods or episodes of BPPV where she had to undergo the treatments, and she was self-taught to manage these herself. But day to day she was still experiencing a lot of the symptoms that went with this. One of the most important things that we did to start with was that she went and had her driving assessment so that she could return to driving herself. Because one of the most distressing parts for her was that she was travelling in a car, her symptoms were significantly worse than when she was stationary, obviously, but also much more than she was when she was able to drive herself. So after she was able to drive, we did a lot of kind of journeys to increase her confidence, and she found that her symptoms were much, much less when she was driving independently. We then looked at returning to work. Her job was working as a nursery teacher in the baby room and toddler room of a nursery. Now this, for anybody with BPPV or vestibular issues, is a massively challenging environment. Not only have you got lots of stimulus with noise, with children around, children are very unpredictable as to where they'll go. So it can cause a lot of problems with balance and feeling quite disorientated. So what we did with this lady initially was that we started return to work, where her and I would spend 20 minutes just in the environment of the nursery. We then looked at her spending time sitting in the nursery, so not interacting with the children, but sitting in the environment that they were in. Then looking at her spending 20 minutes interacting with the children, and we gradually built it up over a period of time, where she was spending an hour in the nursery, but she was having to have significant rest periods, because for this lady the fatigue aspect of her brain injury started to become more apparent in line with her return to work, but also with the vestibular issues that she was experiencing. So we did a lot of education with her employer, who were fantastic, understood massively. They didn't include her in the numbers so that we could do this phased return to work. Unfortunately, due to unforeseen circumstances, she was unable to continue with that employer. But the reason that she's not here today is that she actually is now working full-time in a school as a teaching assistant within a school. So that for her means that she, with the work that she's been able to do in terms of vestibular rehab, she's managed to return to a workplace, so she's back to a valued member of the team. She's, for her own self-confidence, she's able to drive herself there, she can drive around in her local area. She still continues to attend her gym on a regular basis to make sure that she's continuing to maintain her strength and her core stability and all of the kind of exercise work that allows her to feel safe in her own mobility. But she's functionally back to where she feels she was before her injury. She's now married, she's looking at having children of her own, but she every now and then she still experiences periods of BPPV, so it's important for her to know that that is something that may crop up as time goes on, but she has the tools and the experience of how to manage these things, which she does independently now and with the support of her now husband, and hopefully that she'll continue to flourish. So hopefully that's been a whistle-stop tour of the functional side of rehabilitation for vestibular problems, and the important thing at the moment with the COVID situation is that we remember that people have got less opportunity to access the wider community, which can impact on their symptoms. So sometimes some clients are reporting an increase in symptoms with social distancing and with being in lockdown. They've got less opportunity to access the gym and strengthening activities because a lot of the gym facilities have been closed. So it's important that clients have a home exercise-based programme to maintain that. Increased anxiety for everybody, I think, during the COVID pandemic has meant that an increased anxiety for clients with vestibular problems on top of already having an increase in symptoms. We just have to be aware that we maybe need to do a little bit more input at the moment. Also, because of social distancing, environments are less busy, so clients will have less exposure to their symptoms because the environments they're going to aren't going to be as busy as they were potentially before. So just bearing in mind that a lot of clients may need that little bit of support in the future, and that they continue to need treatment where possible. So thank you for listening to me today, and these are my contact details if anybody wants any further information. Thank you.